Hello, I'm Manoj Karmakar. Welcome to ISSPS TV. In this upcoming video, Dr. Shahridan Fathil from Malaysia, as part of the live demonstration, will be demonstrating to you how you can perform point-of-care ultrasound of the airway and lung. If you like any of our videos, do remember to like and share it with your friends and colleagues. If you are new to this channel, do remember to subscribe so that you can get regular notifications of any upcoming video. Now enjoy the upcoming video. Yes, Shah, everything is looking good.
Okay, Mike, can you guys hear me?
Yes, loud and clear.
Okay. Okay. Hello, everyone. We meet again. The first part of this demonstration is airway and breathing. So let's start airway. So we are going to use linear. As probably if we could recall the lecture given by Professor Soy, I think that's quite extensive. So in the interest of time, I will concentrate on the airway ultrasound per se, particularly from the thyroid right up to the trachea, and also demonstrating on the esophagus, particularly if we are doing confirmation of endotracheal intubation. Okay, so linear probe, the marker will be, so this one. Okay, so again by convention,
Sean, can we get your technician to put the picture in picture?
Okay, picture in picture, guys.
Because we can only see the ultrasound image, but not your and the transducer view.
Yes, I think they've got a problem with the camera. We are sorting out.
Okay, that's fine.
Just
Go
hang on
ahead.
for a minute. Okay.
Yes, you're live, back live now.
Okay. Okay, guys. Okay. So again, as I mentioned, linear probe by convention, the marker will be on the right side of the patient. If we go transverse, if it's longitudinal, we will put it capillate. So as I mentioned earlier, we are going to scan right up from the thyroid cartilage right down the trachea. I don't have the gel pad like what Professor Soy showed earlier. So we are going to probably use quite a bit of gel to actually facilitate our scanning, our ultrasound examination. So just kind of roughly put it on the anterior part of the neck here, and you will see some structures which I will explain in a short while. Okay, one important bit is actually to look at the centrality of the airway. Okay, this is probably best done in the longitudinal view, particularly if you're doing with a trauma case or a case with goiter where you want to confirm that the airway is where it should be, which is in the central part of the neck. So usually I would turn in a longitudinal fashion, and I will look for this. So this is the cursor, please. So we are looking for this. So basically the hyperechoic line. Okay, and when you have this, you know you are actually at the central part of the airway. Okay, there are hypoechoic structures here which I will explain to you. So, as earlier mentioned in the lectures, I'm just gonna. What you see beneath is actually artifacts. They are reverberations, kind of like an A line of the airway, if you like. So okay, what we are seeing now, okay, there are hyperechoics. I'm trying to stabilize this. Okay, the one right on top of the hill, so to speak, is actually the cricoid cartilage, and subsequently the one down to the caudate will be, this is the first ring, second tracheal ring, and so on and so forth, the third ring. And if you go further capillate, what you will see is actually here is the thyroid cartilage, and this is the cricothyroid membrane. So as discussed in the lecture earlier, if we are really interested to actually mark this in a possible difficult airway, so I would like to use, I would use this view rather than this view, and what I would do is actually bring it right in the center of the ultrasound image, and I would stabilize it and mark it left and right. So that will determine that and communicate and draw a line between 2 points, and that will tell me in the case of an emergency that is a point where I would like to puncture in the cricothyroidotomy. I've had in the past assist my ENT surgeons for formal tracheostomy to actually look for the actual rings. These are in obese patients, so these are also important to understand. Again, the hyperechoic, the cursor, the hyperechoic line, which tells you that you are actually inserting the central part of the airway, the trach, and these are the tracheal rings. So that's important. Okay, why? If you find this image and it's not really in the center of the neck, for example, you find it here, then you know that you're dealing with a case on airway deviation for various pathologies. Okay, coming back to the airway, we are going to turn the airway into a transverse view, and I'm going to explain the various structures that we are going to see. So let's start from the top. Okay, if you find this triangular structure, you are actually seeing, the thyroid cartilage. And can you see this movement? Can you see that the vocal cords are moving? So this is the thyroid cartilage with the view of the vocal cords deep. And if you go further down, it's probably a bit difficult to, this is actually the cricothyroid membrane, as pointed out, but it's not easy to actually appreciate. So what I normally do if I really want to look for the cricothyroid membrane is to look in the longitudinal view. So if you come from the triangle, of course, in the female, it'll probably be less triangular compared to the male. And then you come down, and when you reach this is more like a box-like structure, if you like. So it's a bit, this is the coid cartilage. And then as you move further that, you can see the thyroid glands, the solid organs. So you are actually now insinuating the trachea, and then as you go down and down, you will see the trachea. So the most hyperechoic line is actually the air mucosal interface, and the lines below it is technically artifacts, the A line of the airway, if like. So another point before we move on to the lung is actually I think beneficial to appreciate the esophagus, particularly if we are planning to use as a form of ETT, intubation confirmation. Because the esophagus is usually situated is definitely on the left side, but sometimes it can be actually quite difficult to visualize because of the fact the part is actually behind the trachea, and it's not actually, you're not actually looking at the whole length of, the whole cylindrical esophageal structure in a cross section. So we managed to find it here. So swallow gently. Can you see that movement? So this is actually a bit of the peristalsis. This is actually the esophagus. So you can use this view for ETT confirmation, placement confirmation. And of course, if you, in the case that you advertently intubate the esophagus, what we will see is actually the esophagus is lifted up. The left lobe of the thyroid gland is usually pushed up a bit. I know we don't see much of movement usually in the case of the correct endotracheal intubation, but occasionally we can see described by Adi itself in one particular study that you see this double tram line. It's probably not easy to see, basically the inner and outer layer of the ETT. Another way of actually confirming it is actually to inject a bit of saline in the, what do you call this, in the pilot balloon so that it inflates the cuff, and usually sometimes we can see a bit of what we call like a snowstorm appearance in the ETT, in the ETT cuff. I think that will probably be enough for airway at the moment. Okay, let's move on to the lung. For the lung, I will use curvilinear. I think there was actually a question of what's the, one of the attendees asked the best probe. As I mentioned in my lecture, you can use most of the probes. The linear with of course, because of the fact high frequency and lower penetration, it's actually quite good to actually study the pleura, particularly in patients with chronic disease. But in most situations, the curvilinear is particularly the better probe, or in like Daniel Lynch advocates, the microconvex is probably the best probe to scan the lung. Okay, I'm going to do a longitudinal anterior, and then I will show you the diaphragm on both sides, the left and right. So again, this is, I'm going to put my probe on the left side. It's basically similar on the left and right, but of course the left you have the heart that you have to mind. So I'm going to decrease the depth. Okay, so what you're looking for is actually what we describe as the bat sign. So the bat sign technically is actually so the head of the bat, and actually the shadow of the rib becomes the wing of the bat. So this is what you're going to see in the longitudinal scan. Okay, let's concentrate. If you put just a interesting remark, if you move the probe medial, okay, just disregard the heart. Can you see this? Actually, you can see the whole pleura. What happens is that this is actually what we are indicating the costal cartilage. So the cartilage is not obstructing the ultrasound waves, so we can see the whole pleural line beneath the costal cartilage. But if we move back lateral, this is what you will see, the bat sign again. Okay, let's now look at the pleural line. I'm going to sometimes, if we have difficulty in appreciating whether it's sliding or not, do this. I can reduce the depth and then look at the movement. I believe everybody appreciates that this is actually moving. It's actually moving. The shimmering of the pleural line. Okay, and what probably it's not best in this system to see the reverberations, but these are actually A lines. And of course, again, as I mentioned in my lecture, A lines is physiological. There are no B lines demonstrated at this particular point. Okay, I will now go to the bases. So the first one, I will show you the diaphragm on the left side. So the left, as it's best to appreciate solid organs on the left side, which is the spleen, again, and the kidney. So this is splenorenal recess. Okay, and then if you move carefully, you will see the diaphragm, which probably in some situations it may not. There is actually a rib shadow that's obstructing it, but this is the diaphragm. And you see this is a curtain sign, the sliding sign just above the diaphragm. So this is important to appreciate, particularly if we are dealing with consolidations, because the consolidations can be hepatized in nature, so hepatization in nature, and as we examine the lung with ultrasound, you want to know whether the hepatization is actually the lung, hepatized lung, or is actually a solid organ intraperitoneally. So if you move further up, you can see there may be one or two beams, if you can appreciate here. Yeah, it goes all the way down. So again, it is pathological when it's 3 or more in a particular intercostal space. Okay, we are moving now to the right side. Okay, the camera will move accordingly. So this is on the left side, is the probe needs to be more posterior. The posterior axillary line is the best, whereas on the right side is probably adequate to be on the mid axillary line. I'm just going to deepen the image a bit further. Okay, and increase the gain. Okay. Is that the way around, is it? Okay, but okay. So it's best to actually visualize the Morrison's pouch. So that's the liver and the kidney. So because this is important, and the diaphragm is probably better visualized here on the right compared to the left. And again, this is the sliding sign or the curtain sign, if you like, on this point. So when we are actually looking hard for the fusion, you ought to, if you want to be thorough, you can actually move the probe further down to the posterior axillary line and to rule out a possible fusion or hemothorax. So if you are doing a screening in a patient who is actually in respiratory distress, the 4 points, anterior and posterior or posterolateral, will be the best screening lung ultrasound examination. Of course, if you want to be a bit more thorough, you need to go, as I mentioned, the topograph 1, 2, 3, 4, 1, 2, 3, 4 again, and of course at the back. But in the case of a quick lung ultrasound examination, the 4 views, which actually the views of the extended FAST, is actually quite good enough to actually reveal the pathology that we are dealing with. Okay. Do we take any questions for this, Manoj? Or
I think let's get Adi to do the second half, and then we can do a little short discussion.
Okay.